Dr. Narula is a good friend of mine, and he is the Phillip and Harriet Goodhart Chair of Cardiovascular Medicine, the Chief of Division of Cardiology at Mount Sinai Morningside Hospital, the Professor of Medicine, Radiology, and Health System Design and Global Health at the Icahn School of Medicine at Mount Sinai, also the Associate Dean for Global Health, the Director of Cardiovascular Imaging Program, Mount Sinai Health System. He's an Executive Director of JAC. He's an Editor-in-Chief Emeritus of the Journal of the American College of Cardiology Imaging, Editor-in-Chief Emeritus of Global Heart. He's Editor-in-Chief Emeritus of Heart Failure Clinics of North America. He's the Vice President-elect of the World Heart Federation. And I'm not going to go on because his CV has 206 pages, and he's got over 880 publications and over 1,500 publications overall. He's a great friend, and today he's going to give us an idea if coronary artery disease will be eliminated in our lifetime. Maybe not in ours, but in some of the younger crew we have here, probably that's going to be the case. So Jagat, thank you very much for doing this. I knew we were going to have you and your wife here these days, but you know, things have changed quite a bit. So thanks again, and I'll leave it to you.
Thank you, Carlos. Truly honored to be presenting some of the fantasies that I have and discussing with you, with Dr. Fedak, and Jim White is there. And thank you, Karina, for all your help in setting this up for today. So as we try and discuss about the possible elimination of the disease, I was actually salivating, to be very honest with you, that I will be in Calgary, one part of the world which I have not been to. And I was presuming that I will be able to look at all those things. And I had planned for a 5-day trip, was very keen to go to Banff also and all. And Carlos, thank you, my dear good friend. I found one of your this caricature online, which I really loved, and I have preserved it for my future discussions or talks, which I give when you are in the presence. So although I couldn't do it, so I'm just happy putting these pictures on screen and looking at them and seeing what a beautiful part of the world I'm missing today and presenting it. So, when I start talking about it, as a matter of fact, when I was given one of these topics of can we eliminate rheumatic fever in our lifetime, and that was the topic which Magdi Yaqub and Salim Yusuf had given me once, and I was very happy that I would be able to talk about rheumatic fever, which was my PhD topic. It was my thesis topic, and I'm very keen in rheumatic fever. However, when I looked at the whole program, I realized that elimination of rheumatic fever was being spoken about by Salim, and I was supposed to have talked about the elimination of coronary artery disease. And I was like 3 days before the meeting in Egypt, and I'm just scrambling around and seeing whether I can put something together based on my work, based on what I have read, and how exactly can I discuss it. But the more I read about it and more I tried to put it all together, I realized that it is indeed a possibility. The only thing is that we really need to think differently, and we really need to discuss differently. So let me start with one of the slides which I have often shown in my presentations. And this is from 1992, as you would see here, that the President Clinton has just won the election. And he is now, this is January of 1993, actually, when he was in the office, and he was subjected to the first physical examination as the President of the United States of America. And at that time, you would see that almost everything looks very normal. Blood pressure is like, for today, it might be called borderline, but 130/70. His fasting blood sugar is also like borderline 104. he was subjected to the treadmill test, and he went to Bruce stage 5, almost athletic capabilities, and he reached 91% of the maximum targeted heart rate. There were no electrocardiographic changes. He had a myocardial perfusion test also, which was absolutely normal, and he assumed his office with a certificate of immortality. Now, every single year thereafter, he was subjected to the Bruce protocol treadmill test, and every year he came out with the flying colors. Essentially, every year he was told that he has no coronary artery disease. Now, this is 1999, those fateful days. And as you would see here, that he has total cholesterol of 196 and LDL of 130. Normal for those days, because we used to consider total cholesterol of 200 at that time and LDL of 130 as normal. So he still has everything which is well within the normal limits for the president. This is 2001, and he's now relinquishing his office. And as you know, that there is nothing in the public database thereafter. And until now, everything which is seen here, all the details I have taken from yahoo.com. So essentially, there is no confidentiality breach here. But then thereafter, there was nothing in the public domain. And when in 2001, when he was leaving, his cholesterol and LDL both had jumped 40 points, as you can see here. We do not know whether he was not prescribed statins, or whether he was on statins or not on statins, whether he was compliant with them. But since there is nothing in public domain until 2004, almost 3 years after his relinquishing the office, that he was back in the news. He had unstable angina, and he required an urgent quadruple bypass surgery. So now, in the person whom we did not know that he had coronary artery disease, he had an acute coronary event. Within 3 years of we having known that he does not have coronary artery disease by our standard practice. Now, I bring you to another person here. And here you would see Tim Russert. And what you would see in this particular case is that we did know that he had coronary artery disease. So this was 2008, April of 2008, that he underwent the cardiac examination, went to his primary care physician, followed by the cardiologist. And as you would see, that he had absolutely normal stress test, although there was some calcium in his coronary arteries. He had impaired glucose tolerance. He was on all the meds which were guideline-based medicines at that time. He was on them, and he was, since his stress test was normal, he was told that he does not have any significant coronary artery disease. And just about 6 weeks later, in June, he had sudden death when he was interviewing one of the diplomats in the office. So in this particular case, we did know that he had coronary artery disease, but we knew that he did not have significant coronary artery disease by our standard definitions or standard protocols, but he died suddenly. So in the first case, we saw a person with not a known coronary artery disease having an acute coronary event. And in the second person, we are seeing that the person was known to have coronary artery disease. We called it insignificant coronary artery disease, or not a significant coronary artery disease. And he had an acute event within 6 weeks, and he died suddenly. What is it that determines the significance of the coronary artery disease when it comes to myocardial infarctions or sudden death? It is something which is not determined by the stress tests or your imaging studies. It is something which is determined by the pathomorphology of the plaque. Here you would see that this is one of the coronary artery lesions from a person who had died suddenly. And in this, you would see that there is a huge plaque. You can see that there's a large amount of the plaque all around, with a lot of eccentricity here. But in this particular area, you'll see that there is a huge necrotic core. You can see significant amount of necrotic debris here, and it is all covered by a very thin fibrous cap. This fibrous cap normally is very intensely inflamed. And here you would see that at the thinnest site, it has given way so that the necrotic core comes in contact with the luminal blood. And since it is thrombogenic, or there's a lot of tissue factor and some of the other factors in there which cause the formation of a thrombus, this thrombus partially or completely occludes the lumen, causes the sudden death or acute event in such cases. Now, if you will compare this plaque with the plaque which is not likely to result in an acute event, or so-called a stable plaque, you will see that these plaques again would have a huge amount of plaque. This plaque you can see is full of collagen and fibrous material. You can see a lot of glistening areas as shown by the blue arrows. These are all the calcification, areas of calcification. In this particular case, you would not see much of a lipid. And here you would see that the fibrous cap, which is present right from here to about here, you can see that this whole area is a fibrous cap or a very thick fibrous cap. This plaque is a stable plaque, and this plaque is not going anywhere. Here you would see that the lumen is significantly occluded or compromised. In this case, the lumen is moderately compromised, but then it gets compromised when the acute event occurs. Now, the same plaque which you had seen earlier, now I bring it to you in the histology or a histological section at that level. Same necrotic core zone, as you can see, significant amount of necrotic debris, lot of intraplaque hemorrhage, very thin fibrous cap ruptures at this site, give rise to the formation of a thrombus, which results in an acute event here. You can see that there are other areas of the necrotic core also in this particular case. So essentially, you can see that there are certain very well-defined characteristics of the plaques which result in an acute event. One, that these are large plaques. They are huge plaques, as you can see here. These are not flimsy plaques. Flimsy plaques normally do not rupture. So these are big plaques. They have large necrotic cores or huge necrotic cores. They've got very thin fibrous cap. The fibrous cap has ruptured at this site. These caps are normally significantly inflamed by the cells of monocyte macrophage origin. Now, two more patients that I would try to show you on the right-hand panel. Right-hand above panel, you can see similarly large plaque, huge necrotic core, very thin fibrous cap. At the thinnest site, it ruptures, give rise to the formation of a thrombus. The thrombus had filled this lumen, but has fallen off when we were sectioning it. So you'll see that a plaque rupture has occurred again here also. The third plaque, again, you would see that this area is full of necrotic debris, lot of cholesterol crystals, which you can see as the cholesterol clefts here, very thin fibrous cap. Here, the necrotic core is almost circumferential necrotic core. There's a very thin fibrous cap. The cap has ruptured here, led to the formation of a thrombus, which occludes the entire lumen, and the patient has a sudden death in this case. Now, in these three patients, or in these three deceased patients, you will see that the plaque characteristics which have ruptured are essentially the same. Large plaques, large necrotic cores, thin inflamed fibrous caps, and then there is a formation of a thrombus on a plaque rupture. Now, the difference in these three plaques is, here you will see that the lumen is not affected at all. In this, the lumen is modestly affected, and in this, lumen is critically affected. So the plaque ruptures can happen even when the luminal occlusion is not, the luminal compromise is not much. However, the amount of the plaque volume or the necrotic core volume is not small. It is never small. And the reason that you can accommodate such a huge necrotic core without much of a luminal occlusion here is because something that happens to the vessel wall, that first the vessel moves outwards or expands outwards. Something what you call as expansive remodeling or so-called positive remodeling. And this remodeling can occur as long as the external elastic lamina accommodates the expansion of the plaque. Once that cannot happen, after that, the plaque comes with vengeance and there is a rapid growth of the plaque inside, and the luminal compromise starts to occur. So this phenomenon is something what is known as we all know, is known as Glagow's phenomenon, because this was first described by Glagow in the autopsy series from the University of Chicago back in late 1980s and early 1990s. Now, this is something which I have often demonstrated by comparing George Orson Welles and Claudia Schiffer. Now, you can look at the two axes in Claudia Schiffer. There's a difference of about 33%. And you can see the two axes in George Orson Welles. There's a difference of about 33%. The only difference, major difference in the two is that whenever there is the significant adiposity or the lipid deposition, this axis moves outwards, or something what you call as the positive remodeling, while when there is no adiposity, this axis moves inwards. So whenever you have a luminal stenosis, which is fibrous luminal stenosis, you have always a negative remodeling or inward remodeling, while whenever there is a significant amount of fat, you see significant amount of positive remodeling or so-called expansive remodeling. Now, this is something when the event has already occurred. What if we have the same characteristics and the event has not occurred as yet? So this is something what you call as high-risk plaque, or the plaque that is vulnerable to rupture. Now, in this particular case, you will see all the features which were similar in the plaque that I had shown you for the plaque rupture. But the difference here is that this fibrous cap, which is extremely thin, and thinness of the fibrous cap here, or the thickness of the fibrous cap here, you can see which is enclosed within the two arrows. It was approximately 85 microns here. And in this case, you would see that the fibrous cap is still intact, although all other features of the plaque are similar. That is, it is a huge plaque, large necrotic core. There's a lot of intraplaque hemorrhage here, and then there was a significant amount of inflammation which was seen here. And if I show the same plaque to you now in histology, you would see that there is a huge necrotic core, as you can see here, almost occupying half of the vessel, large amount of necrotic debris, including large amount of cholesterol crystals or free cholesterol here. You'll see that there is a very thin fibrous cap. It is thinnest at this site, and you will see that there is a large amount of inflammation that you can see by this blue hematoxylin stained areas in this plaque. However, the fibrous cap is still intact. And the similar things you would see in similar type of the display, that here you have less of a luminal involvement, modest luminal involvement, critical luminal involvement, but the plaques which are vulnerable to rupture, they all have large necrotic cores, very thin fibrous caps, and there is a significant amount of positive remodeling. Lumen not affected or minimally affected, modestly affected, and significantly affected in the right lower panel. So now we do see that there are distinct features or histomorphological features of these plaques. Question is that which is the feature which is most important? And if it is most important, would we be able to identify them in the living being? So what we did was that with Dr. Virmani, who is a pathologist, cardiac pathologist par excellence, as you would all know, with her in her lab, I looked at 300, almost 300 hearts, 200 and some hearts, and we segregated them as those which had plaque ruptures, those which had vulnerable plaques, and those which had stable plaques. And then we jumbled up all their histological characteristics, and we put them all together and subjected them to hierarchical importance analysis, which is called recursive partitioning analysis. So we tried to identify as to which were the most important. left side of this slide, that the red is showing the rupture plaque, the vulnerable plaque is in blue, and the stable plaques are in green.
Jagat, we're losing your sound.
Is that better?
That's better. Yeah, thanks.
Thank you. So here you would see that this is the ruptured plaque, this is vulnerable plaque, and here there is the stable plaque in green color. And if we analyze them, we find that the most discriminant feature here is the fibrous cap thickness. If the plaque is stable, all these subjects had fibrous cap thickness of more than 85 microns. On the other hand, those who had less than 85 micron thickness, they were either plaque ruptures or plaque vulnerable plaques, which had still not ruptured. And then we took them to second level of recursive analyses and partitioning analyses. And what would you find here? That again, what becomes important is the fibrous cap thickness. Those which had ruptured were all less than 55 microns as compared to those who had not ruptured but were vulnerable, suggesting thereby that most of these plaques which are vulnerable have the fibrous cap thickness between 55 to 85 microns. However, we all know that measuring such a fine thickness of 55 or 85 micron, it cannot be done by any non-invasive means, at least for now. So the only thing that you can do is you can use the optical coherence tomography, which has the resolution of approximately 10 microns, that we can identify the fibrous cap thickness. And we do that very often in our cath lab here. But what would be amenable to a non-invasive test? So to do that, what we did was that we excluded the fibrous cap thickness as an available histological entity for our partitioning analysis. What do we find now? On the right-hand panel, you will see that the fibrous cap thickness is now not available. What do we find? There are two things which turn out to be most important. Number one was the amount of inflammation. Here you would see that in the macrophages here are minimum, and the people who had plaque rupture, they had maximum amount of inflammation. And then the second step was, when we did the partitioning again, we found it was the size of the necrotic core. Here you would see that the necrotic core size in the stable plaques, if at all it was present, was very small as compared to those which had ruptured or which had vulnerability to rupture. And then we went on again, and it turned out to be macrophages again. And then we went down, it was necrotic core size again, macrophages again, necrotic core size again, suggesting thereby that essentially two features which are important in such patients is the amount of inflammation and the size of the necrotic core. So can we really identify that by the non-invasive imaging modalities? So this is how my career in this area started. So when I started to look at the CT imaging, and I was lucky that Toshiba had just came up with they came up with the 64 slice CT, and I was lucky to get the first machine of theirs, which was given to me as a gift when I was in UC Irvine. And essentially the Toshiba America medical system was in our backyard. So it was a huge gift. Expectation was that I would be able to identify the vulnerable plaque on non-invasive imaging. And they had given me the money enough to do 3,000 cases and run a full-fledged lab. And we did multiple teaching courses and things like that for about 3 years after we received the equipment from them. So this is one of our first papers. And as you can see here, that we compared the CT images from the subjects with 16 initially and later on 64 slice CT scanner, and compared them to the intravascular ultrasound and tried to identify as to what would be the Hounsfield unit densities of the plaques which have necrotic core. Here you would see that the necrotic core is there, as you can compare it with the intravascular ultrasound on the left-hand panel. And here it is about 5 Hounsfield units. And we found that it was always less than 30 Hounsfield units, which corroborated with the necrotic core on the intravascular ultrasound. The fibrous plaques were between 30 and 150 Hounsfield unit density, and the contrast in the lumen ranged between 150 and 350, while the calcium was always more than 350 HU. So realizing that we probably would be able to differentiate these plaques and we will be able to go beyond the lumen, we started to look at the subjects who came to us with the unstable angina or acute MIs, but they were of low risk category. That is, the pain had occurred more than 24 hours ago. So we were able to take them to the CT angiogram before we did the coronary angiography on these cases. And as you can see here, that the subjects who had had the acute coronary event, they had distinct features. And as you can see, this is the left anterior descending coronary artery from a patient who had unstable angina. And you can clearly see that the lumen is about 50% occlusive. You can see the contrast in the LAD. But then if you follow the vessel here, you can see that there is a huge amount of positive remodeling, as I'm showing by the yellow arrow here and yellow arrow here. It looks more like George Orson Welles here. So this positive remodeling. And then the second important thing was that you will find that there is a large amount of low density areas here, or low Hounsfield unit areas here, less than 30 Hounsfield units, which is a necrotic core, which ranges right from the top of the plaque to the bottom of the plaque. So huge necrotic core right along the entire plaque here. So we called these plaques as soft plaques and submitted our second paper for publication to Journal of American College of Cardiology. Somehow or the other, reviewer did not agree with me, and reviewer continued to say, how can I see that this is a soft plaque? How can I see that this is a vulnerable plaque? How can I say that this is the plaque which has given rise to the acute coronary event in this case? Now, my only submission to Jack was that these were the people who had single vessel involvement. And if there was a single vessel involvement, that they have a single vessel disease, only those patients we had collected, 30 some patients that we had, that there is no other way, there is no other lesion that can give rise to anything like this. But the reviewer would not agree with us. And they wanted me to call it or give it some kind of a non-specific name. So since there were two very important features that I found, one was the positive remodeling, and very well convincing from the pathological perspective also. And second was the low attenuation plaque, or LAP, what I call them as LAPs. So the low attenuation plaques and positive remodeling, I thought there are two features which are important, and I called them as two feature positive plaques. And the reviewer was very happy with two feature positive plaque, and he accepted the paper. God bless him, he took the paper, and the whole thing became a lingo. Now in the CT field, you will find people calling them as two feature positive plaques, three feature positive plaques, four feature, depending upon how many features have they used. So this continues to be a non-specific terms which has essentially taken over the field. Now you compare it to the stable plaque here, you will see that if at all there is a waste here, there is a negative remodeling. In this particular case, goes more with the Claudia Schiffer's waste here. And you will see that there is a critical lesion, 99% lesion at least, but there is no positive remodeling, and you don't see anything like this, which is a low attenuation plaque. And I call them as two feature negative plaques. Now, this is again when the event has happened. Can I identify these plaques which have two feature positivity and they still did not have the acute coronary event? So here is one of the examples which was the most inspirational cases for me. And this was 57 years old, long-standing hypertension, male, controlled hypertension. He came to us in 2006, early morning chest pressure, and he was seen in the ER. Blood pressure was 175 over 100, and the electrocardiogram was kind of normal. And he was ruled out with the serial electrocardiograms and enzymes, and CT angio was performed before the discharge. Here you will see a similar plaque, positive remodeling, large necrotic core, some spotty calcification, but only about 40% luminal occlusion. So this is the first septal branch here, and the lesion is in the proximal part of the LAD. So I wanted this patient to go for intravascular ultrasound and to confirm that the subject has the lesion, which is as low as we are seeing here. Wise patient, he asked me whether is it going to make a difference to his management, and I told him no. He does not have likely a significant lesion, and I will nonetheless discharge him on the statins and increased antihypertensive agents. So this patient refused admission, refused intravascular or intracoronary investigation, and went home. 6 months later, he comes back. And now there is no doubt about it. Presentation is essentially the same. And we take him to the cath lab straight. Now, if you remember, the lesion was just before the first septal branch. As you can see here, that the lesion is the same lesion, suggesting thereby that the 2 feature positive plaque or 3 feature positive plaque with the spotty calcification that we were seeing was the culprit plaque or was the vulnerable plaque for this particular subject. We went ahead and did 1,000 cases who had at least 2 years of follow-up, and we found that the likelihood of having an acute coronary event over the next 2 years was 22.5% in the people who had 2 feature positive plaques. The 2 feature negative plaques had less than 0.5% likelihood of having an event, giving us a hazard ratio of approximately 45:1. Now we can identify the necrotic cores. Can we also identify the inflammation? Very difficult to identify the inflammation. And one of the tricks that has been used is with the help of FDG imaging also. So PET CT has allowed us, because the macrophages or inflammatory cells, they don't have the endogenous machinery to produce much of energy. So they depend upon the exogenous glucose. And if you give them the labeled glucose, there's a significant uptake of it. Here you would see in a patient who has gotten a stent, and you can clearly see the significant amount of FDG uptake in that stented area. There is spontaneous uptake in the left main bifurcation here, and there is a significant uptake in the aortic root in this case also. So you can see that the FDG can localize in the areas of the high risk plaques. Now, if and this is not seen in the patients who get the stent placement for the stable lesions. Recently, it has been demonstrated by Stefan Achenbach and his collaborators from Oxford, Charis Antonides, that the areas around the plaque, the adventitial areas around the plaque, they are less inflamed, and they have less of the fat in those areas, or they start to turn more fibrotic if there is a significant amount of cytokine production in the neointima. And they have demonstrated that if we create a hypothetical circle around the vessel, which is as thick as the vessel diameter is, we will see that the remote part of fat has a different Hounsfield unit densities as compared to the perivascular fat, and they call it a fat attenuation index, and clearly demonstrate that there is a significant difference in those who have had worse outcomes versus those who had better outcomes. However, the Hounsfield unit density difference is so little that I am yet to be convinced that this would be used as an important clinical tool in near future. Now, when we are discussing about all this and we are thinking that we will be able to identify all these plaques which are likely to result in an acute event, here comes a study from my mentor, Dr. Fuster. And Dr. Fuster did this study, and this was presented not too long ago, approximately 2 years ago. And it was shown in European Society of Cardiology meeting as well, that if you look at the comprehensive atherosclerotic burden, you will see that almost all the people who have two cardiovascular risk factors have some kind of a atherosclerotic burden. And they would find fat also, they would find inflammation also, they would find the fibrous cap thickness. So MR done here, PET scans done here. And so this was a fabulous study where he tried to demonstrate that you would be able to see the lipid pools almost everywhere. But the question here is, are these lipid pools truly necrotic cores? They truly are not. And you would see that if in a given person, if I find that there are 200 fibrous plaques and 200 lipid pools, the vulnerable plaques will only be 2. So essentially, a very small percentage of, 20, a very small percentage of them, less than 10% of them are going to be the plaques which are vulnerable plaques. And that capability we still do not have. That whether we would be able to differentiate between a lipid pool versus the exact necrotic core, which leads to the formation of the atherosclerotic, high-risk atherosclerotic plaque. So now, if I look at these plaques, what do you see in these cases? That as I discussed, that the plaques which are two-feature negative plaques, they have less than 0.5% likelihood of having an event. While those which are two-feature positive, they have 22.5% likelihood of having an event, giving us a 45:1 hazard ratio. But now, which is the plaque which is truly the plaque which is going to result in an event? So we started to look at multiple things in these cases. So as you would see here, that the number of the high-risk plaque characteristics, more the number of the high-risk plaque characteristics, more they are likely to have an event. So there are two important things here: dose and the quantity. So bigger the necrotic core, higher the likelihood of having an event. Larger the number of the high risk features, higher the likelihood of having an event. Not only that, if the plaque, now this is our last study of this kind, which was published in 2015, where we had increased the number of our patients to 3,000 and follow up to 10 years. We found that high risk plaques are high risk plaques, 10-fold higher likelihood of having an event over the next 10 years as compared to the plaques which are non-high-risk plaques. However, now we have started to see that high-risk plaques are not as benign as they were at 2 years' time. At 2 years' time, there was less than 0.5% likelihood of having an event, while now there is approximately 2.8% likelihood of having an event. So almost 3% likelihood of having an event when there is a high-risk plaque also, suggesting thereby that many of these plaques which were non-high-risk plaques to start with, they do grow into the high-risk plaques over the ensuing years. So what will be the plaques which will be plaques which will be amenable to rupture? So one important thing that we find out is that high-risk plaque, if is significantly stenotic also, it would be more likely to rupture as compared to the high-risk plaque, which is not stenotic. And this is very reasonable to believe, because when you have a high-risk plaque and you have got any hemodynamic perturbance, for example, blood pressure spike or any other endothelial damage or vasospasm or anything else that is happening, it will be more effective when you have a high-risk plaque in association with a stenotic lumen. More important than anything else which we have found is the plaque progression. Now, what is plaque progression? Where the size of the necrotic core increases significantly. And if you remember we had earlier discussed that the plaque or the necrotic core can only expand unless until the external elastic lamina allows it to expand. After that, it will start to grow inside. So now this is the plaque progression, and this will cause more of a luminal stenosis as well. Now, here you would see that the high-risk plaque, if progresses over a period of time, here we have 500 cases where we have 2 serial CT angiograms done at 1 year apart. So you will see that those which show plaque progression, there is a significantly higher likelihood, 35 times higher likelihood of having an event as compared to the plaques which are high-risk plaques, but they do not demonstrate any plaque progression over that 1 year. So here you would see that almost none of these people which had the high-risk plaques but did not progress over the next 1 year had an event. However, a high-risk plaque, non-high-risk plaque with a plaque progression did over a period of year, suggesting thereby that progression is also one of the very important events that we really must follow. So if I put it all together, and Amir Ahmadi, who comes from the lab of Dr. Jonathan Leipzig from Vancouver, who now works with me and has been doing a lot of work on the CT angiography, we came up with this natural history of coronary artery disease paper in JACC about a year and a half ago, where we tried to demonstrate that all the people here would have the plaque in their second and the third decade of their life, and there is a gradual progression of the plaque that continues to occur until there is a rapid progression of the plaque. And once there is a rapid progression of a plaque, that is the time when the plaque progression occurs, when the progression reaches a threshold here. So essentially, this rapid progression time is the time which somehow or the other would be our most important target to find if we really want to identify the patients who are likely to have an event. Until now, what you used to feel was that anything before an event is primary prevention, anything after the event is the secondary prevention. But what I would like to suggest here is that our secondary prevention should start to occur as soon as we start to see the image-based plaque formation, and we should start the prophylaxis there, and that would be called the secondary prophylaxis, while the primary prophylaxis will be when we do not have any evidence or any phenotypic or imaging evidence of having the atherosclerotic disease. Now, how does it correlate to the hemodynamics here? Because FFR is becoming the most important thing these days. So how does it correlate to the FFR? So here you would see that if you have the FFR of less than 0.8, you will see that there's a 10% likelihood of having an event. Now, if you have FFR of more than 0.8, where the patient was deferred and no intervention was performed, you'll see that if the patient had more than 3 high-risk plaque features, there was 15% likelihood of having an event, suggesting thereby that these plaque features do play upon the hemodynamic features. So more the hemodynamic features, lower is the FFR, and more the plaque characteristics, lower is the FFR. And this correlation we demonstrated in one of our studies, the NXT studies or next study, again the study done by Dr. Bjarne Nogard from Denmark and Jonathan Leipzig, and they were too kind to give us all their cases, and we reanalyzed them and found that FFR was determined by 2 most important things. One, which is the luminal compromise, which we can see, or the quantitative luminal stenosis, and the second was the presence of the low attenuation plaque volume or necrotic core. So until now, we used to think that it is only the luminal stenosis which determines the FFR, but now we demonstrate that it is the presence of a large necrotic core which also demonstrates, or which also influences the FFR and reduces the FFR. Why does it do so? Because at the plaque site, if there is a huge necrotic core which has expanded to the maximum, that is to its Glagov's limit, that is that beyond which the external elastic lamina does not go anywhere, or the medial cell layer does not go anywhere. Now you give them any vasodilators, whether it is a tenosin or it is nitroglycerin or whatever else, that area creates an area of functional stenosis. So the large necrotic core, unlike the fixed luminal stenosis, the large necrotic cores can cause functional stenosis when you give them either vasodilators or when possibly the patients exercise. And that is probably the reason that FFR does a lot better than the luminal stenosis alone when we compare these two approaches to the decision about revascularization. Let me give you an example of a patient. This is a 72 years old patient, a very well preserved patient. He has typical chest pain, and he has the previous medical history of dyslipidemia. He has been on rosuvastatin 10 milligrams. He is CEO of a big company, and he has a family history of premature coronary artery disease. His father had a massive MI at the age of 50, and that is why he's scared, and he has the best of the characteristics, lifestyle characteristics, exercises well, eats well. Now, quite afraid, so he comes and does his CT angiography with us, and he has some 25 to 50% lesions. And as you can see here, that there are certain areas of small lesions, but most important thing that you would see here.
Jagat, we're losing you again.
Better now?
Yep.
Here you would see that the FFR is significantly lower. It drops from 0.89 here to 0.76 here. And this lesion was less than 50% lesion. Now, if I look at the luminal stenosis, there is hardly any luminal stenosis, but you will see that there is a huge necrotic core sitting at this site. So you sit down with the patient. He does not want to undergo interventions. He does not want to undergo angiography. And since I told him that he has a large necrotic core, he agreed to take a large dose of the rosuvastatin. We increased it to 40 milligram. We added ezetimibe. And on a follow-up, here you would see that LDL from 110 has fallen to approximately 45 milligram percent. And as you can see in the second angiogram, that the lipid core has reduced significantly. The fibrous cap has increased significantly in this case. And what would happen to his FFR? From 0.89, it is now 0.86, suggesting thereby that the pathophysiology plays hand in hand with the pathology of the disease. Now we have put all our risk factors together, and this is the paper which is coming out in JACC Imaging. And here we have taken 75 features with in Dr. Kwon Koo's lab from South Korea, and in approximately 1,000 patients, we demonstrate that the 25 were very important features which were very reproducible on auto learning or machine learning. And out of these, there were 6 which were found to be most effective with their maximum information gain, as you can see here. And these were the necrotic core, the percent atheroma volume, the remodeling index, the total plaque volume, the minimal luminal area, and the proximal presence in the proximal LED lesion. And then you add the percent diameter stenosis and FFR to it and see what exactly happened. If I look at only the luminal stenosis here, this is what the C statistics to you would look like. And if I add the FFR, it improves significantly. And if I add the plaque characteristics here, it becomes a much, much better fit, suggesting thereby that all these three things eventually will need to be taken care of. So in the last few minutes, I would like to wrap up and suggest what exactly can we do. So this is the study that I bring from Dr. Salim Yusuf, Dr. Carlos Morelos' very close collaborator. And I think Dr. Murillo was one of the important contributors to this study, the Interheart study, which was done in 52 countries, 27,000 subjects. And it is one of the best studies of our time that we have seen. In this particular study, you had seen that the patients who had heart attack were compared with those who were presumed not to have coronary artery disease, and various risk factors were looked upon. The four risk factors, which are the standard risk factors: hyperlipidemia, smoking, hypertension, diabetes, and then the two risk factors which were added by them, which is the obesity and the mental stress, and three protective factors, which is abundant use of vegetables and fruits, the modest use of alcohol, and intense physical activity. And here are the odds ratios of these risk factors and the protective factors. And if you look at the population attributable risk, you will see that the two features alone explain 2/3 of a disease. Four regular standard risk factors explain 75% of a disease, and 90% of the likelihood of having a heart attack can be expressed if we have a knowledge of all 9 risk factors. Now, singling out one risk factor, if you see here, which is the hypercholesterolemia, which was measured as ApoB to ApoA1 ratio. In these cases, you will see that there are deciles of this ratio on the x-axis, and on the y-axis you would see the odds ratio of having a heart attack, and you'll see that there is a directly proportional relationship. As the hyperlipidemia increases, there is an increase in the likelihood of having an event. And this was not that it was limited to one particular area. It was any country you go to or any continent you are in, the odds ratio remained almost 4:1 for the hyperlipidemia. And something similar was seen for all 9 risk factors that they presented. So whichever country or continent you are in, hyperlipidemia happens to be one of the most important markers. Now, the question is that can we really tell that if I did not have hyperlipidemia and if I had not developed hyperlipidemia, would I really be able to do better as compared to those who have hyperlipidemia? So what we thought was that why do we not try and identify a population where there was no hyperlipidemia, where people lived much better, where there was no McDonald's and no Kentucky's Fried Chicken, where we did not smoke, where we did not have the cars and the air pollution and the secondhand smoke. If I am able to reach out to that population, I probably would be able to identify that these features do indeed contribute to the disease. And if I don't have these features, then we probably can get rid of coronary artery disease. So with that view in mind, we went ahead and we took the permission to do the imaging in the mummies, which are available across the world. So there are about 600 mummies which are available in various museums in the world. And then we also went to South America and we tried to see some of the mummies from there also, specifically in Peru. So here is some of our earliest data coming from Egypt, that we have this, we took these sarcophagi and we took the mummies out of there. We imaged them on the CT scanners and tried to look at the coronary, if then coronaries were available, coronaries, otherwise other large vascular calcification in these cases. So this is approximately 3,500 years old mummy here. And what would you find? I had expected that I would see absolutely zero calcium in these cases. But to our surprise, this was one of the mummies where the heart is still intact. You can clearly see the right coronary artery and left anterior descending coronary vessel. There is a significant amount of calcification in these two vessels. There is also the iliac bifurcation and aortic calcification in this particular case. And then the mummy that came out of this sarcophagus, which showed significant amount of vascular calcification in these cases. So now the issue was, if there is a calcification in these cases in Egypt also, obviously that means that the risk factors should not be playing a role. However, when we started to look at their diet, the way they lived, the way they existed, it all demonstrates that their lifestyle was essentially no different than what we have. These people used to consume the food at least 3 times a day, because they had an access to animal husbandry they had started, and they had started cultivation. 3 times a day the food will be made, and they would be consuming it 3 times a day. They would be carried on palanquins, because these are the Egyptian elites. The people who would be, every day there will be festivities, and they would have the delicacies, and the delicacies would be the bird eggs of different sizes. So we thought that we really need to reach out to the population which did not have these limitations of the richness or the eliteness. So we ended up in Peru. In Peru, the people are put into the mummy bundles, as you can see here, and they are put into the knee elbow position, because you have got to go back to the afterward same way that you came to this world. So you are in knee elbow position. You are wrapped in the bundles, and you are thrown in the ground. And ground has a lot of salt there, lot of soil which is full of salt, and they naturally get desiccated. So these are not mummified artificially, unlike Egypt. These are the naturally desiccated or naturally mummified bodies. So we did their similar way. We did their CT angiograms, and as you can see here, that although I had expected that now I will not find it. Why? Because they are all farmers, manual laborers. They all live in the foothills of Andes mountain. They go up and down the mountain. So they exercise enough. They eat, 50% of them consume vegetarian diet. 50% of them consume alpaca, which is a very lean meat. So I thought that we really have the right population. But what we found, that 25% of them also had evidence of large vessel atherosclerosis, as compared to about 35% of the Egyptians. Now, what was wrong here? Until we went there and did the autopsies, and what do we find? We find that only those cases had atherosclerosis who had black lungs also. And why did they have the black lungs? Because they used to cook inside these huts or the homes that they lived in, and there was a lot of air pollution which caused the black lungs and which caused the atherosclerosis. And essentially this atherosclerosis occurred more in the younger women, because they were the one who were involved more in cooking. So then we went somewhere near you, and these are the Aleutian Islands, and we thought that these are the hunter-gatherers. They eat sometimes, then they many days they are not able to hunt, and they would not be able to eat. And these are the people who have lived on the subsistence level. So we got 5 mummies from there, which are in the University of Pennsylvania museum, and we were able to image them. And so here is the Aleutian Island area. And so this was that these are the people who are very, very physically active and are eating minimally. They should not have a problem. So what do we find in them? See the right coronary artery here. Look at the aorta, which is full of calcium. Look at the aorta, which is full of calcium here. So significant calcification in these cases. 3 out of 5 cases had more calcification than I could even imagine. The reason was that they lived in the subterranean or underground houses that they made for themselves, and they would light fire here. There was only one area from the smoke would leave up in their ceiling. So essentially, they all lived in the smoke-filled houses, and that is probably the reason they had the problem. Something similar we saw in the southeast of Utah also. So then we thought we really need to get to, and these are the last 3 slides here. that we get to the populations, living populations, which live better. And we ended up in Bolivia. And so these areas of Bolivia, the Chimane population that lives there, those have not seen much of the world as yet, and they still live quite like the old agrarian or the hunter-gatherer type of a lifestyle. So here is it that we are flying into the Santa Maria from La Paz, and we took the small canoes to get to the Chimane areas. This is the river Manuki, which is a big tributary of Amazon and flows northwards from Bolivia. And here is a center where we went and saw them and examined some of these people. Here is a 99 years old woman. Here is her 85 years old husband. And here you will see how they lived in those areas. Whole day they walk around. They try and hunt for monkeys, jaguars, or pigs. And they clock about 17,000 steps a day on an average, if not more. And here you would see this is the meat that they get. They are preparing the meat. Or there are some wild fruits which are available, quite like plantains or some papayas that you can see here, that these are the ones which are available. And what do they do is that they use this meat or use with these fruits, and they create stew which keeps on simmering for the whole day. And they just have one meal at the end of the day because there is a little food that is available to them. We have now 3,000 carotid ultrasounds in them, about 4,000 cardiac ultrasounds, and about 700 CT scans in these people, not these CT scans, but the CT coronary calcium scores in these people. And as you will see here, that I have compared the MESA data, which is on top, with the MESA data on the left-hand side and the Chimane data on the right-hand side, men on the top and women on the bottom. And here you would see 25th, 50th, 75th, 90th, and 99th, 95th percentile here. And the same thing for the Chimane population. Lowest ever reported calcium score for any living population in the world. Essentially, there is hardly any calcium that we see in their men or in women. This is 75% type here, that you hardly see any calcium in these people. And if you compare them to the United States of America, whites, blacks, Japanese, Chinese, Koreans, Hispanics, anybody, and compare them to the Chimane, which is on the bottom here for men and bottom here for women, you'll see that there is no coronary calcium here. And this is what summarizes everything here, that they do at least 15,000 steps, less than 10% sedentary time. There's no air pollution. Their lifetime LDL has been less than 70, lifetime blood pressure of less than 115/70, lifetime sugar of less than 80, lifetime BMI of less than 24. They have no calcium or minimal calcium there throughout the life. And the question is, if they can have it, why can we not? So would like to end with this slide here, that if you look at the cholesterol of all the animals in the world, whether you look at the various mammals, as you can see here, or even if you look at the wild primates, or even the hunter-gatherer humans, cholesterol has been less than 100, always. There is only one animal in this world which is proud of 208 on an average cholesterol in United States, and that is human. Why is it so? Not only that, coming again from Salim Yusuf's lab, and again, you know, he brings out one after the other classy studies that, so I'm grateful to Sonia Anand for having given me this slide, what they call as a family study, where now they are collecting the 10-year data. They followed from birth and looked at all the risk factors. This is cholesterol. The child is born with less than 30 LDL, which in 3 years' time reaches between 130 to 150. What do we do to them? What do we feed them? What exactly are we inducing which makes them to increase their cholesterol level to 130 to 150? And this was after our study was published in Lancet. This was the big editorial that came in New York Times, Heart Healthy in Amazon, and we should learn from our parents' mistakes. So I would like to end with a quote which I stole from Salim Yusuf, and with his permission, he was sitting there, and I was writing it on a napkin when he talked about it. The death of diseases. He said that our grandchildren will not know what cardiovascular disease is, and they will ask us, "Grandpa or Grandma, it must have been a terrible time when there were all those nasty diseases, plague, smallpox, polio, and heart disease. Why did those diseases die?" And we should be able to say, "Son, we were able to take care of the risk factors." Thank you.
Much, Jagat. That was a fantastic, great journey there. I don't know if there are any questions. I didn't see any questions on our chat box. We're a little bit over time today, unfortunately, but that was great. Now let me ask.
Carlos,
Yes.
can I ask a question?
Yeah, sure. Go ahead.
So, do you think coronary endothelial dysfunction contribute to plaque progression, instability, and rupture?
Say that what contributes to plaque progression?
Coronary endothelial dysfunction.
Oh, sure. So the endothelial dysfunction is the start of the disease. So essentially, the entire process starts with the endothelial dysfunction. And once there is an established vulnerable plaque and all, endothelial dysfunction definitely can give rise to or would contribute to the plaque rupture. It can indeed, because of the vasospastic issues and some of the other issues where the vasodilatation cannot occur, or where it would contribute to the shear stress which arises in the significantly stenotic areas. So yes, endothelial dysfunction indeed is a major issue.
There's a question here that asks: "Is do you think eating less than 3 meals a day is of benefit?" So,
Men versus women issue here. So essentially, women have an advantage, and at least in the premenopausal stage, although we have all been given to understand that we cannot neglect the disease. The reason being, what part we cannot neglect. So the few important things which happen in women which we must not neglect are those that they can have significant plaque erosions instead of having the plaque rupture. So the plaque rupture is less likely in the premenopausal ages, while instead they could have the plaque erosion. And the plaque erosion is where you do not have much of the necrotic cores and all. The luminal compromise is minimal. There is no positive remodeling. And one of the most important risk factors there is the cigarette smoking. So that plus the microvascular dysfunction, we have heard a lot about it, but there are not much good evidence for that. But yes, there is a possibility of the microvascular disease in them as well. Why is it that they would have less of the plaque rupture, less of the necrotic core, or less of the fatty deposition in the disease? And what I normally feel is that women are a much stronger species than men are. And I say it scientifically because what exactly happens is that they have significantly large number of the endothelial progenitor cells. Now, why would they have so much of endothelial progenitor cells as compared to men? And I would speak in the laymanish term here, that every month there is the menstrual cycle that they have to support in their premenopausal times. At that time, the endothelial progenitor cells are produced because after the entire endometrium is shed, they have to develop an entire endometrium over the next 14 days. So you can imagine the amount of progenitor cells that they have to produce or they have to consume. And it is expected that they have the endothelial progenitor cells to the tune of about 1,000-fold more than the men. So what will happen is that even if I have the risk factors, in men, it will cause the endothelial damage. For example, hypertension, cholesterol, and others. But in them, when you do that, there will be something which will be available. There's so much of circulating endothelial progenitor cells that they will innocently come and repair the losing endothelium in the coronary arteries and other vessels. That's why they get protected. Only one thing which endothelium cannot tolerate is the smoking. And the smoking still leads to the plaque erosion in women. So, well, do women have advantage? Yes. But do they lose advantage? Absolutely yes. Immediately upon menopause, disease comes with vengeance. Their rapidity of increase is significantly more. The rate of progression is significantly more when they lose all that protection. And that is the reason, although they remain about 10 years behind men, but there is a significant increase. And sometimes I try and put it together with what we see in the transplant vasculopathy, the way the disease starts to occur there. It is essentially something similar, which keeps on happening in women after menopause.
So another question here from one of our staff, Dr. Weeks, says that we have all had patients who exercise, eat incredibly healthy, have no risk factors. Is not the genetic profile also of significant importance?
Yeah, absolutely. Absolutely important. And I apologize that I did not put my slides on the genetics in there. And I try and not to distract people by putting in the genetics, but yes, genetics definitely has a role to play. And again, outstanding data that come from Shekhar Kathiresan's lab in Boston, as well as Dr. Sonia Anand and Salim Yusuf's lab from the Interheart study itself, that we have seen that there is a when the genetic profile is favorable for the development of coronary artery disease. And as you can see that now gradually the number of the SNPs and number of the polygenicity is gradually increasing. Shekhar Kathiresan used something like 50 genes, while 50 SNPs, while Salim's lab used approximately 1,000 of these SNPs. So as the numbers increase, there is a significant demonstration of a relationship here. And now recently, Shekhar Kathiresan has again shown the presence of the clonal hematopoiesis of indeterminate importance and chips. So what they have tried to show is that these are the somatic changes which happen also in these cases. But all put together, both Shekhar's lab, which was a wonderful New England Journal of Medicine paper, and Sonia Anand's paper, which was in Journal of American College of Cardiology, they have demonstrated that when you have more prudent diet and more prudent lifestyle, you will cut down on the risk for more than 50%. So yes, we are born with problems, but if we live a proper life, and if we are able to avoid the risk factors, we basically would be able to avoid the disease. So that is the disease which gives you a susceptibility to coronary artery disease. But more important is that coronary artery disease has to happen in the presence of the risk factors. And if we are able to avoid the risk factors, we should be able to avoid the disease. That's one important thing. And the second important thing is that when we say that they they live a good life and they have minimal risk factors, what is a minimal risk factor here? So the two important things there also, number one, that the risk factor, when we say the cholesterol of 100 is normal, is that normal? No. When I'm born with 30, why should I have the cholesterol of LDL of 100? So can I bring it down to 30? Why not? And then similarly, what is the blood pressure levels? What is the sugar level? Do we really, are we talking of the usual value which has been given to us by the epidemiological study of the population which is at risk of dying from the premature vascular disease? Or are we talking of a real normal value? So that is one most important thing that we really need to identify in these cases. And then the second small thing which I would like to say is that it is always the minimal increase in 1, 2, 3, or 4 multiple risk factors, then a significant increase in one risk factors, which will cause the problem. So it is not that I should be looking for a hypercholesterolemia of more than 1.
We lost you there, Jagat. Sorry. So anyways, thank you very much. That was incredible. So other than moving to the Amazon, should we be taking a low dose of colchicine or something like that?
So colchicine basically would start having an effect when I have already started having a plaque and LDL deposition in my arteries. That is what I believe. I mean, like, the inflammation is not going to occur. Inflammation per se cannot happen and cannot lead to the coronary artery disease. It has to be that the cholesterol has to be in my plaque before the inflammation starts to occur. Now, there could be a possibility that that there is a disproportionate inflammation, and those are the cases which will respond to, quite like the Jupiter study did. But I do believe that colchicine comes much later. Rather than taking a colchicine, I would better take a statin.
So the next poly pill is a combination of a statin and an anti-inflammatory drug.
I think I would be happy with just a simple plain pure statin, and I'm very happy with that. I don't need a polypill in my mind. I mean, I know I'm going against too many very powerful investigators of the world who talk about polypill. In my opinion, keep your LDL to 30, nothing would happen to you.
Okay, Jagat. Well, that was great. Thank you very much again, and hope to see you soon, eh, my friend?
Thank you, Carlos. Grateful.
Take care.
Thank you. Bye-bye.
Bye now.